Welcome to this webinar looking at surgical options in reflux. My name's Marianne Hollyman. I'm a consultant upper GI surgeon working at Somerset Foundation Trust. Before you start watching this webinar, I'd recommend you catch up on the other webinars in this reflux series, which include reflux diet and lifestyle advice and medications and reflux disease. These two webinars give more detail about the diagnosis initially of reflux and the basic medical treatment, which is an important background. So the question is, when should you consider surgery for reflux disease? Reflux surgery is not appropriate for the majority of patients, and factors that may make us consider whether an operation is appropriate would be a patient's unwillingness to remain on lifelong medical therapy, if they're intolerant to taking medical therapy, if you have continued symptoms despite taking the maximal medical therapy you're able to do, or if you have some complications specifically related to your reflux disease, which can include things such as Barrett's esophagus, or some people may have a hoarse voice or cough due to significant reflux up to the back of their throat. It's obviously a matter of patient choice, and obviously if a patient is interested in exploring more about surgery, then we can move on to some initial investigations. So the first thing when we assess a patient about whether or not they're suitable for surgery is assessing whether they have risk factors that can be removed and potentially remove the need for an operation. This has been discussed previously in the diet and lifestyle reflux webinar. So there are some risk factors that can easily be modified, such as smoking, and most surgeons would not agree to proceed to an operation in a patient who continues to smoke, as your symptoms may resolve with stopping smoking. There are other risk factors, such as having central obesity, which increases the pressure in your abdomen and therefore makes it more likely that acid will reflux up into your gullet. Obviously, some things can be done to help lose weight, but not all patients will be able to lose enough weight to get rid of their symptoms. Also, if a patient presents with significant reflux in pregnancy, an operation is obviously not the right thing for them, but can be considered after the pregnancy if they have persistent symptoms. So when we move on to investigations, all patients should undergo an endoscopy before they proceed to an anti-reflux operation. Endoscopy is a common procedure where we put a camera down the gullet and stomach to have a look for any pathology inside. This helps us understand whether or not reflux is the correct diagnosis, or if there is something else going on inside the patient that might explain their symptoms. The endoscopy is normally done as a day case procedure with either a bit of spray at the back of the throat or occasionally some sedation. The actual procedure itself normally only takes around 5 minutes and is well tolerated by patients. The things that we're expecting to potentially find at an endoscopy in a patient presenting with reflux is possibly a hiatus hernia. The hiatus is the gap in the diaphragm where the gullet passes through and the stomach lies below this in a normal patient. And in a hiatus hernia, the stomach is herniating through that hole and moving up into the chest area. A large percentage of the population may have a small hiatus hernia with just a centimetre or two of the stomach above the diaphragm, and some patients can have significant hiatus hernias with almost the whole stomach above the diaphragm. The presence of hiatus hernia does not always correlate with reflux. So we see people who are suitable for a reflux operation who have no hiatus hernia, or we see plenty of patients with a hiatus hernia where it's causing no symptoms. So don't be concerned if this is a finding or not on your endoscopy. One of the other factors we look for is damage to the lining of the gullet due to reflux. This may be in the form of esophagitis. Mild esophagitis isn't always associated with significant reflux. So if there is mild esophagitis, we may need to do further investigations to confirm there is reflux. In the presence of significant esophagitis, we know that there is a significant amount of acid going into the gullet on a regular basis, and we don't necessarily need to do other tests to confirm there's high pH in this area. Some patients may suffer with Barrett's esophagus, which can be a precursor to cancer, and therefore it's important to identify this early in that patient group. If you have had a hiatus hernia found at the time of the operation, your surgeon may ask for further imaging, which may be in the form of a test called a barium swallow, where you swallow some contrast and some x-rays are taken to assess the size of the hiatus hernia and the flow of fluid or contrast through the stomach. The surgeon may also ask for a CT scan to assess for the size of the hole at the hiatus, and also potentially to assess for the length of your esophagus, as this may be important in operative planning. Patients will commonly be sent for pH manometry studies. The manometry studies are mandatory really in patients undergoing anti-reflux surgery, as we need to understand what is happening with the pressures within the gullet. There'll be a small number of patients who have increased high pressure in the gullet and may have a condition called achalasia. And these patients do very badly with anti-reflux surgery, so we need to identify this before the procedure. The manometry studies involve a probe being placed down the nose, as shown in the picture, and the patient is asked to take a series of swallows so we can measure what the pressure is like as a swallow goes down to assess whether this is within normal limits or abnormally high pressure. As I mentioned before, some patients, we may know that they have had a high pH of acid in their gullet due to the changes of esophagitis, but those who haven't had significant changes may still have significant reflux, and therefore we do pH studies in these patients. pH studies will normally last for over 24 hours with the probe down the nose, again, as shown in the picture, and the patient is sent home with this probe in to measure what a normal day is like for this patient. So we expect the patients to go about their normal daily activity so we can measure what a day in their normal life is like. The probe measures when there's a high level of acidity in the gullet, and this is recorded on the box recorder, again, shown in the picture. The patient is given a button to press, so when they have symptoms, we can see whether it correlates with the episodes of high acid level in the gullet. Patients will be asked to stop their anti-acid medication before the procedure, normally for around 7 to 10 days to get accurate readings, and some patients may find this difficult to do if their symptoms are quite significant. So once we've got the results of all these tests, we can make a decision on whether or not an operation may be suitable for the patient in terms of we think it may give them a good outcome. But as there are risks to this operation, we need to obviously have an important counselling session with the patient about whether or not their symptoms are severe enough that they're willing to take the risks of the operation. Post-operatively, patients should expect that they may have some difficulty swallowing as we're tightening things up at the bottom of the esophagus. This hopefully in most cases will be transient over the first few weeks, but it may be persistent in a small number of patients who might either need additional endoscopy or dilatation of this area, or some patients may need reoperation, and patients may have other side effects which include bloating, increased flatulence and belching. So the risks of the surgery can be divided between the risks at the actual time of the operation and risks post-operatively. Around the time of the operation, with any operation, there is a risk of bleeding. Overall, with most anti-reflux procedures, the risk of bleeding is fairly low, and maybe about 1 in 100 patients may need to have something additional needing to be done due to bleeding. There is potential damage to internal organs as the area we're operating in, as well as operating on the gullet and the stomach, is very close to the liver, the spleen, the heart, and major blood vessels that run behind this area. In general, it's very low risk that any of these things would be damaged during initial operation, but it is potentially possible. There is a chance that the operation may fail. This can be that the symptoms may persist despite having carried out what seems to be a successful operation. And overall, around 1 in 10 patients may feel that their outcome is suboptimal after the operation. There is a need for reoperation in the short term. Around the time of the operation, around 2% of patients, and overall around 10% of patients may have some sort of reoperation in the years following this procedure, as the repair may become undone or they may have other symptoms related to it. And as I've mentioned before, a lot of patients can have some difficulty in swallowing, with belching and vomiting and gas bloat, as they cannot bring the air up, it goes down, and unfortunately this may increase flatulence in some patients. So when we're counselling patients for an operation, we want to work out which patients we think will likely to have a good outcome. And we know that those patients that actually have a really good response to their potent prompt inhibitors, PPI medication, will often have a very good result from an operation. And the main motivation then for doing the operation is to come off that medication long term. Patients that we've identified as having hiatus hernia, because we correct that as part of the operation, often will have a better outcome. And those patients that have what we call volume reflux, so proper regurgitation of food or food up to the back of their throat or in their mouth, because again, the tightening will get rid of those symptoms, patients often have a good result. Those patients that we've shown to have either esophagitis or Barrett's esophagus, where we can see that the acid in the gullet is making significant damage to the tissues there, often have a good outcome as well. So what does surgery actually involve? After you've had the counselling with your consultant surgeon and you've had your pre-op assessment, you'll be brought in on the day of surgery. Most operations are normally done as a keyhole operation, with a very low chance for this needing to be converted to an open operation. Some centres offer day case anti-reflux procedures, but the majority of patients will stay in 1 or 2 nights for the actual operation. Around the time of the operation, you'll often be asked to wear stockings on your leg to reduce the risk of clots in your leg travelling to the lung, and you may also be given injections to thin the blood to reduce those risks. So the most standard procedure to get rid of reflux in the UK is a fundoplication. Most commonly, this is referred to as a Nissen fundoplication, which is what is demonstrated in the images here, which is taking the top of the stomach and wrapping it round the back of the gullet and stitching it to itself. So it's called a 360-degree wrap. So the stomach is wrapped all the way around and stitched to itself. This is creating new sphincter at the bottom of the gullet to help prevent acid refluxing up. If the patient does have a hiatus hernia, this will be reduced before the fundoplication is performed. There are a range of other types of fundoplication that may be performed, which include a toupee, which is similar to the Nissen, but only a 270-degree wrap, so it is not stitched to itself, it's just stitched to the stomach, which is a slightly looser wrap, or there are alternative wraps which go in front of the stomach rather than behind. But this is the range of most common operations performed, and this will normally be done as a keyhole procedure. Post-operatively, as I've said, the majority of patients will stay in hospital at least 1 night after this procedure, and they will initially be started on fluids, gradually building up to liquid food, puree, mashed food, and over around 4 to 6 weeks will be back to normal diet. Patients may find it particularly difficult eating foods such as bread or red meats after the operation, and we advise patients chew food well, drink with plenty of fluid, and if they find that certain foods are particularly difficult to swallow, then potentially to avoid these in future. So as I've mentioned, a lot of patients will have some degree of swallowing difficulty after the operation, and this is because we have tighten things up, and there will also be swelling at this time. We do expect most swallowing problems to resolve over the first few weeks, but there will be a small number of patients who will have to have endoscopy to confirm whether or not things have opened up enough, and occasionally a dilatation or repeat operation will be needed with these patients. So there are some alternatives to the fundoplication. In those patients who have a BMI of over 35, who we haven't managed to reduce this significantly due to basic lifestyle measures, we know that patients have a very poor outcome from the fundoplication, and around 50% of those patients will have a failure. In this patient group, it may be appropriate to offer a gastric bypass for weight loss, as this has the advantage of both being a good operation for anti-reflux, but will also help with weight loss in this patient, which is a modifiable risk factor which will help with their symptoms. It will not necessarily be able to be offered in all trusts, as not all trusts offer weight loss surgery, but it is something to consider in those patients with a higher weight, as it will likely have a better outcome. There are a couple of other alternatives, newer designs, slightly less evidence about how they can be used, and aren't always so easily available on the NHS. One is LINX, which is a string of magnetic beads that are placed laparoscopically around the top of the stomach to help create a new sphincter there. So the magnetic beads hold together, stopping the acid coming up at normal times. But when a food bolus comes down the gullet, then the magnets move apart and allow that food to pass through. It does have the disadvantage that if you have a significant hiatus hernia, it can't be performed, or it can only be done with patients with small hiatus hernias. And the majority of people would need to search for this outside the NHS if they felt this was the right option for them. Another alternative is Stretta, which again is not commonly performed in the UK and is more available in the private sector. This is an endoscopic procedure where electrodes are placed down to the bottom of the gullet across where the muscles should be to help hold the top of the stomach closed. There is low frequency current put through them, which heats up the tissue and leads to increase in size of the tissue or hypertrophy of the tissue in this area, which reduces the amount of reflux in the future. So in summary, I would say that anti-reflux surgery is an option for some patients, but is not suitable for all. And it's only really for patients with significant symptoms, which they feel are affecting their life on a daily basis. And you really feel that the risk of the operation is outweighed by the benefit it may give to you by having it performed. As I've said, some patients may still need to keep taking medication despite anti-reflux surgery, and around 1 in 5 will still be on a PPI following the operation. I would really want to ask that everyone make sure they look at the modifiable risk factors before considering surgery, which the two main ones would be considering weight loss and reducing smoking, and anything that can be done to reduce stress would be great as well. And just be aware that there's obviously quite a lot of additional investigations that will need to be carried out before we can assess you are suitable for surgery. And there will be some patients who do not meet the criteria following those investigations. Thank you very much for your time today.